Hi, and welcome to Radonc Talks, a lecture series created for students and residents of radiation oncology. My name is Ria. I'm currently a fourth-year Radonc resident at the University of Pittsburgh, and welcome to Part 2 of SRS for brain metastases. In Part 1, we reviewed some basic aspects of management of brain SRS and discussed some history and basic principles of SRS, including considerations for gamma knife versus LINAC-based SRS. We then started getting into some evidence, mainly talking about trials pertaining to the dose when we're doing brain SRS, whether we are treating in a single fraction for tumors less than 2 centimeters or fractionated SRS for tumors that are larger. In this talk, we're going to continue learning about more evidence for brain SRS, discussing SRS for multiple brain metastases, as well as SRS plus or minus whole brain radiation, or SRS plus or minus surgery. Finally, we will get into some treatment planning considerations and end with a discussion on toxicity and follow-up after SRS for brain metastases. Let's start by looking at some clinical trials that compare SRS to whole brain radiation. In Part 1 of this talk, we discussed the critical trial RTOG 9005, which was a dose escalation study that established the safe doses for single fraction SRS for tumors less than 4 centimeters. Remember, we said 24 gray for tumors less than or equal to 2 centimeters, 18 gray if they're 2 to 3 centimeters, and 15 gray if they're 3 to 4 centimeters. This particular trial, RTOG 9508, utilized the same dosing established in RTOG 9005 and randomized patients with anywhere from 1 to 3 brain mets less than 4 centimeters in diameter to either whole brain radiation alone or whole brain radiation plus SRS. And what they found is that there was no significant improvement in overall survival whether patients received whole brain radiation alone or whole brain radiation plus SRS. When they just looked at the patients that had a single metastasis, on univariate analysis, they found that there was improved overall survival in the SRS group. However, this difference did not remain significant on multivariate analysis. So essentially, adding SRS to whole brain radiation does not provide an overall survival benefit. When they looked at local control in RTOG 9508, however, they did find that adding SRS to whole brain radiation significantly improves local control. So local control was 71% in the whole brain radiation alone arm versus 82% in the SRS plus whole brain radiation arm, so just about a 10% improvement. There was no significant difference in the overall failure rate within the entire brain, which makes sense because with brain SRS, we're not treating the entire brain, just the areas of tumor. So the big takeaway from RTOG 9508 is that adding SRS to whole brain radiation improves local control compared to whole brain radiation alone. And remember, this study looked at patients with a limited number of metastases, anywhere from 1 to 3 metastases. They did not see an overall survival improvement, just a local control benefit. The next trial we'll talk about came from the Japanese Radiation Oncology Study Group, and they essentially asked the opposite question as 9508. So RTOG 9508 asked if adding SRS to whole brain radiation improves anything, and the answer was it improves local control but not overall survival. The Japanese study asked the opposite question. So does adding whole brain radiation to SRS improve anything? So they looked at SRS plus or minus whole brain radiation. And they took patients with 1 to 4 brain metastases less than 3 centimeters and randomized them to either receive SRS alone or whole brain radiation plus SRS. If tumors were less than 2 centimeters, they were prescribed 22 to 25 gray. If they were over 2 centimeters, they were prescribed 18 to 20 gray, with a 30% dose reduction if the patients were also receiving whole brain radiation. And what they found is that there was no difference in overall survival between the two groups. Both groups had an overall survival of just around 7.5 to 8 months. In the SRS alone group, there was a significantly higher chance of developing new brain metastases, 64% versus 42% in the whole brain radiation group. which again makes sense because when we're treating with SRS, we're not treating the entire brain. We're just treating the area of the tumor. So there's no treatment of the microscopic disease in the brain. And so you do have a higher chance of developing new brain metastases at distant sites within the brain. Additionally, they saw that there was significantly worse local control with SRS alone. So now we're talking about just the area where the tumor is. The local control was better in the SRS plus whole brain radiation group. It was 89% versus 73% at 1 year with SRS alone. So these results do kind of corroborate what we were seeing in RTOG 9508. The other outcome that they looked at was neurological death. And what they found is that there was no significant difference in neurological death between the two groups, no difference in functional preservation or mental status between the two groups. And so this trial is very interesting because it corroborates the results of RTOG 9508 and shows us that whole brain radiation added to SRS really does improve local control as well as distant brain control. However, it does not seem to confer any kind of overall survival benefit, and additionally, there's no significant difference in neurological death. They also performed multivariate analysis to look at predictors of survival versus predictors of distant brain failure, and the results are very similar to what we already know predicts for survival based on our graded prognostic analysis, which we talked about in the first lecture on whole brain radiation. So patients that were less than 65 with a stable primary tumor, stable extracranial metastases, and good performance status, these criteria were all predictors of survival, whereas treatment with SRS alone, greater than 1 brain metastasis, active extracranial disease, and worse performance status are predictors of distant brain failure. So that all makes sense. I think the big takeaway from this trial is that SRS alone in patients with limited brain mets confers increased local failure and brain tumor recurrence compared to SRS plus whole brain radiation. However, there is no change in overall survival or neurological death, which means that SRS alone could represent a viable treatment options for certain patients with a limited number of brain metastases. And the major disadvantage of whole brain radiation therapy really is the decline in neurocognitive function. And so that is why there is this effort to try and spare patients from whole brain radiation so they don't have to have that neurocognitive decline. And this is where another study comes in, a study from MD Anderson by Chang et al. Published in 2009. They looked at patients with 1 to 3 newly diagnosed brain mets and, similar to the Japanese trial, randomized them to SRS alone or SRS plus whole brain radiation. And their primary endpoint was neurocognitive function at 4 months. This trial actually closed early because there was such a worse decline in neurocognitive function in the SRS plus whole brain radiation group. The mean probability of decline was 52% in the whole brain group versus 24% in the SRS alone group, so almost double. And that's why the trial closed early. Now, interestingly, when they looked at the overall survival in these patients, they found improved overall survival in the patients treated with SRS alone compared to SRS plus whole brain. So the SRS alone group median survival was 15.2 months versus just under 6 months in the whole brain radiation group, and that was significantly different. As expected, the local control and distant brain control were much higher in the whole brain radiation group versus SRS alone. So the key takeaway from this trial is that SRS plus whole brain radiation clearly shows worse neurocognitive function. And again, this is in patients with limited brain metastases. So if we can treat them with just SRS and avoid the whole brain radiation at any cost, that might be the better thing to do. Now, that survival benefit in the SRS alone group, I would take it with a grain of salt, just because this was not corroborated by the Japanese study, which we previously talked about. And there have been different explanations postulating why there was an improvement in survival in the SRS alone group. Was it because the groups were imbalanced? Was it because SRS alone received more prompt systemic therapy? It could also be because the SRS group underwent local surgical salvage, and a great number of them actually were found to have pathologically active tumor. So there's different explanations that have been posed. I'm not clear that SRS alone actually provides a survival benefit compared to whole brain radiation, but we definitely know that it provides worse local control, yet these patients have improved neurocognitive function. And that is really the rationale for pushing for SRS in patients with limited number of brain metastases. The Alliance trial, or RTOG 0671, is another trial showing significantly less cognitive deterioration with SRS alone compared to SRS plus whole brain radiation. These patients also reported significantly better quality of life with SRS alone, and they had no significant difference in overall survival. One thing to note is that the total intracranial tumor control is significantly worse with SRS alone. So these patients do require close follow-up with brain MRIs just because of the risk of distant brain failure. So all the studies we've talked about so far tell us that SRS alone for brain metastases provides worse local control, worse intracranial overall brain tumor control, but no difference in overall survival, or at least no worsening of overall survival, and improved neurocognitive outcomes. All the studies we've talked about so far have looked at treating SRS in patients with less than 5 brain metastases. Let's look at some evidence for treating with SRS for multiple brain metastases. There's another Japanese trial, which is very good to know in the context of SRS for multiple brain metastases. It came from Yamamoto et al., published in 2014, and this was a prospective observational study of patients treated with SRS alone for 1 to 10 brain metastases. So up to 10 brain metastases, and none of these patients received whole brain radiation at all. What's important to note is that they only allowed treatment with SRS if the total cumulative tumor volume was less than 15 cc's, and any one tumor had to be less than 10 cc's or less than 3 centimeters in diameter. They adjusted the SRS dosing slightly based on the volume of each tumor. Their primary outcome of overall survival showed no significant difference for the group with 2 to 4 brain metastases versus 5 to 10 brain metastases. It met the criteria for non-inferiority. The overall survival was just around 10.8 months, as you can see in the table. Additionally, they compared toxicity for the group with 2 to 4 versus 5 to 10 brain metastases and found no significant difference. So this trial provides some evidence, again, it's a prospective observational study, but it provides some evidence that SRS alone for 5 to 10 brain metastases is non-inferior compared to SRS for 2 to 4 brain metastases. The maximum number of brain metastases that's safe to treat with SRS at any given time, based on the evidence, I would say, is probably somewhere around 10 to 15 brain mets. But depending on where you work, depending on the institution, practice patterns might vary, and you might see different attendings feeling comfortable treating up to 20 or so brain metastases at any given time. What I will say is that the biggest factor, probably the most important factor when you're evaluating whether or not a patient can receive SRS alone, is the volume of brain metastases. You can imagine that treating with SRS for multiple small 1 to 2 millimeter lesions is a lot safer than treating with SRS for even just 4 or 5 lesions that occupy 3 to 4 centimeters or more in diameter. So the total volume of the brain metastases is really, really important when making these decisions. And actually, it has been shown as a prognosticator in multiple different series. Multiple series on multivariate analysis have shown improved overall survival with decreased total volume of brain metastases. And in fact, total volume is actually more important than the total number of brain metastases. So we've talked about SRS for up to 10 brain metastases based on the evidence now. We know that institutions might take this number up to 15 to 20. We've talked about that adding whole brain radiation to SRS doesn't really improve overall survival, but it does worsen the patient's neurocognitive outcome. What about combining SRS and surgery? The first trial that we'll talk about is a single center phase 3 randomized trial coming from MD Anderson Cancer Center, where they compared postoperative SRS versus observation. So they took patients with anywhere from 1 to 3 brain metastases after surgical resection and randomized them either to observation or SRS within 30 days of surgery. They applied a 1 millimeter PTV margin to the resection cavity and treated with anywhere from 12 to 16 gray, depending on the volume of the resection cavity. The results showed improved 12-month freedom from local recurrence with SRS. So the local control was 72% in the SRS arm versus 43% in the observation arm. They found no significant difference in overall survival and no evidence of radiation necrosis in the SRS group. So this trial from the MD Anderson Cancer Center shows us that postoperative brain SRS improves local control compared to observation. The next trial we'll talk about from the NCCTG compared postoperative SRS versus postoperative whole brain radiation. They took patients with resection of a brain metastasis and a cavity measuring less than 5 centimeters. They were also allowed to have up to 3 additional unresected metastases, and they randomized them to either receive SRS or whole brain radiation. The results that they found are very similar to what we have seen in the prior trials that we discussed comparing SRS to whole brain radiation. SRS alone had improved cognitive deterioration-free survival, so improved neurocognitive results with SRS alone. There was no significant difference in the overall survival, but they did see worse local control with SRS versus whole brain radiation. So this is nothing new. It's what we've already talked about. We know that whole brain radiation offers better local control compared to SRS, but the advantage of SRS is that the neurocognitive deficits are much better with SRS compared to whole brain radiation. Additionally, when they looked at toxicity, the rates of radiation necrosis were 4% in the SRS group versus none in the whole brain radiation group. So once again, what we've already seen in our prior studies, post-operative brain SRS compared to whole brain radiation improves cognitive outcomes but has worse local control and no difference in overall survival. So when patients undergo resection for a brain metastases, if we're given a choice between SRS versus whole brain radiation, we would pick SRS as a supplement just because it has better neurocognitive outcomes with SRS compared to whole brain radiation. And we definitely want to do something because we know that adding radiation to surgery improves the local control in these patients. Now, the question is SRS better to do in the preoperative or the postoperative setting? And to answer this question, we only have retrospective data at this time. And this is a retrospective review of 180 patients treated with pre-op versus postoperative SRS for brain metastasis. The study showed that the preoperative SRS group had certain characteristics which were favorable for treatment. So they had smaller PTV margins, and they ended up having a lower peripheral tumor dose. They still had similar GTV volumes, but you can imagine that after the tumor is resected, it's harder to see the outlines of that cavity. The area becomes a little bit larger, and you end up treating more volume with more peripheral brain tumor dose. So preoperative SRS is a little bit easier and a little bit more favorable from a radiation planning standpoint. In terms of results, when they compared pre-op versus post-op SRS, there was no significant difference in the overall survival, the local control, or the distant brain recurrence. However, they did see that the post-operative SRS groups had higher rates of leptomeningeal disease, 16% versus 3% at 2 years, and they also had higher rates of symptomatic radiation necrosis, 16% versus 5%. So higher rates of leptomeningeal disease and higher rates of symptomatic radiation necrosis with post-op SRS versus pre-op SRS. And as a result, as radiation oncologists, we have retrospective evidence that favors pre-op SRS, and so we do tend to favor preoperative SRS whenever possible, just because pre-op SRS has lower rates of leptomeningeal disease and lower rates of symptomatic radiation necrosis. And if you think about why this might be, it actually makes sense, right? Because we talked about how in the preoperative setting, the conditions for radiation planning are a little bit more favorable. When we're doing SRS in the postoperative setting, we might need to add an additional margin on the cavity just because there's uncertainty when we're delineating that postoperative cavity. In the postoperative setting, patients might also have a variable clinical course that could potentially delay their time to SRS. Additionally, when they're resecting the brain metastasis, there is a theoretical risk of tumor spillage into the CSF, which might explain the higher rates of leptomeningeal disease with postoperative SRS. And so for all of these reasons, as radiation oncologists, we prefer preoperative SRS whenever possible. However, it's not always possible. A lot of times patients come in with neurological emergencies, they're having a lot of symptoms, and they need to be immediately taken to the OR. If you don't have a very rapid way of planning these patients and getting them treated in a timely fashion before surgery, it often doesn't happen until after surgery. So it's really important to establish a close relationship with your neurosurgical team and make sure that you're trying to offer preoperative SRS in a timely fashion whenever possible. So at this point, we have sifted through a lot of data, a lot of evidence, and what I'd like to do now is just show you a quick summary slide with some major takeaways from what we have learned. So just to review some of the major takeaways, we know that adding SRS to whole brain radiation therapy improves local control compared to either modality taken alone. However, compared to whole brain radiation, SRS, either alone or perioperatively, confers worse local control but improved cognitive outcomes at 4 months. So if we're dealing with a patient that has a really good performance status and an expected survival of at least 4 months, we would favor treating with SRS over whole brain radiation. We also know that the volume that's occupied by the brain metastases is more important than the number of brain metastases when we're thinking about both overall survival as well as toxicity. So really pay attention to the volume occupied by all of the brain lesions that you're trying to treat. In terms of dosing, we have high-tech data showing that for lesions less than or equal to 2 centimeters, doses of around 18 gray offer excellent local control at 1 year of over 85%. We talked about how melanoma is a more radio-resistant entity, and so we need to treat with at least 21 gray to get that 85% 1 year local control, but that's just for melanoma. So maybe for single fraction, we don't need to go as high as the traditional RTOG 9005 dosing, which took lesions less than 2 centimeters to 24 gray. Maybe we can just do with 20 to 21 gray. In terms of larger lesions over 2 centimeters, we know from RTOG 9005 and subsequent trials that the local control was worse. And so for these lesions, we really would consider fractionated SRS, for example, 27 gray in 3 fractions. And finally, we know that SRS can be used alone, with surgery and/or whole brain radiation. And so all of these patients should be receiving a multidisciplinary consultation with their treatment approach really tailored to their clinical needs. Great job if you've stuck with this talk so far. We're almost done. I'd like to wrap up now by talking briefly about treatment planning followed by toxicity. Simulation considerations are obviously very different depending on the institution and also if you are planning on a Gamma knife machine versus treating on a linear accelerator. That said, these are some general guidelines that you can try to follow. It's very, very important to obtain a post-contrast T1 weighted MRI with thin slices, so 1 millimeter slice thickness, so that you can very clearly visualize the brain metastases. And it's also really important to pay attention to the time between your MRI and treatment. At my institution, on a Gamma knife machine, the patients typically receive an MRI the day of their treatment. And when we're treating on a linear accelerator, we obtain a stereotactic MRI and try to finish our planning and get the patient treated within 2 weeks of that planning MRI. Some guidance for contouring when you're delineating your targets. So the GTV is really the contrast enhancing tumor on MRI, or the cavity if it's a postoperative setting. Again, it's very, very important to accurately fuse the CT to the MRI if you are planning on a linear accelerator and the plan is being generated on the CT scan. It's really, really important to get a very good registration and make sure that the MRI is properly lined up to the CT. But you draw the GTV, there really is no CTV. We directly add an expansion from the GTV to the PTV, anywhere from 0 to 2 millimeters. Typically what I have seen is 1 millimeter margin used for intact lesions and considering a 2 millimeter margin for either post-op lesions or very small lesions where you're a little bit more unsure of that image registration. Obviously, we're also contouring all of our organs at risk, including the normal brain, our optic structures, brainstem, and so on. This is just a summary slide with some guidance for SRS dosing. We obviously talked extensively about RTOG 9005 dosing, and then we talked about the advantages of fractionating for tumors that are greater than 2 centimeters. And so I just have a little bit of guidance. Typically for tumors less than 2 centimeters, at least at my institution, we think about treating for 20 to 21 gray in a single fraction. And then when it's over 2 centimeters, we consider 24 to 27 gray in 3 fractions. If the lesion is truly very large, over 30 to 50 cc's, we might consider 30 gray in 5 fractions. The postoperative dosing typically requires using 3 fractions just because the residual cavity ends up being larger in size. Preoperatively, on the other hand, we typically still try for single fraction to get it done as soon as possible before they go for surgery. And we typically offer a 20% dose reduction compared to definitive dosing. So we might do something like 16 gray times 1 in the preoperative setting. Whenever you're evaluating these plans, there are a few particular things to be aware of. Now, obviously, plan evaluation is a very complex topic, and someday in another talk, we'll get more into details about how to closely evaluate radiation plans. But for now, what I'd like to mention is some specific considerations when we're looking at brain SRS plan evaluation. So first of all is our coverage. We want to ensure that most of our PTV is getting all of our prescription dose. So let's say our prescription dose is 20 gray, just to make it simple. We want close to 100% of our PTV volume to be receiving at least 20 gray. Remember that these plans are very heterogeneous. So at the periphery of our drawn PTV, everything might be receiving 20 gray, but in the center of our PTV, the dose is actually much hotter and it might be receiving closer to 30 gray, for example. So just because these plans are very heterogeneous and we want to achieve a sharp fall off and kind of spare the dose to the rest of the normal brain surrounding the PTV, there are 2 unique indices that you should be familiar with. So one of them is the conformity index. The conformity index tells us how well does our plan actually conform to what we have drawn for our PTV. So the conformity index is calculated by taking the volume covered by the 100% isodose line. So taking everything that's receiving at least 20 gray or more in our example and dividing it by the PTV volume. So let's say our PTV volume is 10 cc's. And then when we draw a 20 gray isodose line or a 100% isodose line, everything receiving at least 100% of our dose, we see that the volume for that is 11 cc's. So in that example, the conformity index would be 11 cc's divided by 10 cc's, and it would be 1.1. The goal conformity index is anywhere from 1 to 1.2. So, that tells us that we are adequately conforming to our PTV volume. The other equation to be familiar with is what is known as the gradient index. And this tells us how well are we achieving a dose fall off, because we want the We want 100% of the dose to kind of very conformally align to the PTV, and then we want it to sharply fall off, and we want to spare as much normal brain tissue as we can. So the gradient index is the volume that's covered by the 50% isodose line divided by the volume covered by the 100% isodose line. So if we're still using our example where we're treating a PTV to 20 gray times 1, we would take the volume covered by at least 10 gray divided by the volume covered by at least 20 gray. And our goal gradient index is less than 3. If the gradient index is more than 3, then it tells you that the fall off probably is not as sharp as you would like it to be. I think that conformity index and gradient index are a little tricky to conceptualize, and they'll make more sense when you're actually applying them in practice and evaluating a real plan in clinic. The last thing I want to mention here in the context of treatment planning is the dose constraints that we use to evaluate our organs at risk. These are taken from high-tech papers. Keep in mind that the dose constraints are different for single fraction versus 3 fraction. In terms of evaluating the normal brain as an organ at risk, what we really care about is the volume of normal brain receiving a particular dose. So one good numeric to keep in mind for single fraction SRS is that we want the volume receiving at least 12 gray to be less than 10 cc's, and that has been correlated to a 15% risk of radiation necrosis. So V12 less than 10 cc's. For 3 fractions, it's a little bit different, and it's actually V20 less than 20 cc's. So we want the volume receiving 20 gray or more to be less than 20 cc's. Other organs at risk that we care deeply about are the brainstem and the optic structures. These are very sensitive to radiation. So if we're doing single fraction, we want the brainstem to be less than 12.5 gray max and the optics to be less than 10 gray max. If we're doing 3 fraction radiation, we want the brainstem to be less than 18 gray max and the optics to be less than 20 gray max. If you're treating a tumor that's very, very close to the brainstem and the optic structures, you see how low those dose constraints are for single fraction. So you would be much safer by fractionating the treatment to kind of help spare the brainstem and the optic structures. The other one that's up there is scalp. For single fraction, we try for less than 8 gray. That one's probably not as important as the brainstem and the optic structures. The very last section that we'll talk about is what we think about when following up with patients after brain SRS and toxicity from brain SRS. So we talked previously about how SRS does not improve distant brain control. Whole brain radiation treats microscopic disease in other areas of the brain, but SRS doesn't. And so the most likely thing to happen to a patient after they've received SRS to brain mets is that a few months down the road, we see a new brain metastasis in an area of the brain that previously has not been treated. And I tell this to patients when I'm counseling them about what to expect after brain SRS. The most likely thing to happen is that another spot will pop up somewhere that we haven't treated. That is why we really need to follow up these patients very closely with serial brain MRIs. Initially, we like to obtain them every 2 to 3 months, and then after 2 years or so, we feel more comfortable spacing them out, either every 4 months and then every 6 months, if they've shown that they're not developing any new brain metastases. In terms of toxicity, the most feared toxicity from SRS is radiation necrosis to the brain. And there's different mechanisms that have been proposed. There's vascular injury as well as glial cell theory. But essentially what's happening is a lot of inflammation and edema that leads to ischemia, necrosis, and cell death. Risk factors for radiation necrosis are the volume of brain receiving a certain dose of radiation. And so that is why we want to be very careful with our PTV margin. It's why we care so much about the total volume of brain mets that we're treating. A way to try and decrease the risk of radiation necrosis is to provide fractionated treatment for larger tumors. Other risk factors are prior radiation exposure within the brain and also concurrent systemic therapies that might sensitize the cells to radiation and make the side effects from radiation more exaggerated. Diagnosing radiation necrosis can actually be very tricky because when you're looking at MRIs in the follow-up period, it can be really hard to differentiate radiation necrosis from just tumor recurrence or tumor progression. And so it requires a lot of experience, and it's something that's very, very hard to do. There are some tools to help differentiate the two. So one of them is certainly to obtain serial MRIs and look at the changes over time. Does it look like it's a tumor that's growing, or does it look like radiation changes that might be settling out? The other thing that you can look at is something called T1 or T2 matched changes, which I will show you on the next slide. Let's start by looking at the T1, T2 match, which is shown in the 4 images on the right-hand panel. So what we mean when we say T1, T2 match, it looks like they're 2 pieces of a puzzle. So in the T1 image, on both the A and the C panels on the right-hand side, you can see something that's contrast enhancing. It's almost like a rim enhancing lesion. When we look at the T2 image, the corresponding T2, so the B and D images corresponding to A and C respectively, what we see is a lot of edema. So all that brightness, all that hyperintensity represents edema. And in the center of that edema, we see something hypo-intense. So we see something darker that looks like the same shape of what we saw on the T1 image. And that T2 image is showing us that there looks like there's all this edema surrounding a hole. And that hole represents something. And that something is more likely to be tumor. So when we see a T1, T2 match, it's more likely that we're dealing with a recurrent tumor. On the other hand, if we look on the left-hand panel, a T1, T2 mismatch is seen when the shape that's seen on that T1 image doesn't quite correspond to the hole that we see on the T2 image. And in that case, when we see more edema and not a clearly defined shape corresponding to the T1 lesion, it looks like we're more likely to be dealing with edema, and that edema is more likely to be from radiation necrosis. So it's a very tricky thing. It's very, very hard to differentiate radiation necrosis versus tumor progression or tumor recurrence. It's something that I myself need a lot of practice, and I still need a lot of help figuring this out when I'm working in clinic. Just for reference, I wanted to leave you with the scoring systems for brain toxicity. There's a CTCAE scale, and there's also an RTOG scale. As with most scales, grade 5 equals death. Grade 1 is typically asymptomatic, doesn't really require interventions. Grade 2 is moderate with maybe steroids, and then grade 3 and 4 are more severe. The management of radiation necrosis, the first-line treatment is typically corticosteroids such as dexamethasone. You can consider something like 4 to 8 milligrams per day with a gradual taper depending on how symptomatic the patients are. There are other options that are often prescribed in coordination with neuro-oncology. So one drug is bevacizumab. The brand name for this is Avastin, and it's a VEGF inhibitor. So it kind of inhibits that vascularization, which we talked about as a mechanism for radiation necrosis. Another combination of drugs that you can consider is Trental and vitamin E. And another thing I just want to add is that it is really hard to differentiate between radiation necrosis and tumor progression. And if you're not sure about how to diagnose it on imaging, and you're not clear even after serial brain MRIs, then the ultimate way to get your diagnosis is to take the patient for surgery and get a tissue sample. And I have seen cases where that has been necessary. So with that, we are finally at an end of a very long and extremely complicated topic. Thank you so much for listening to everything if you've stuck with this talk throughout its entirety. This is a topic that will probably need repetition and lots of practice in clinic to feel like you have truly grasped it. So I think I will just stop there and let it all sink in. I don't blame you if you feel like your brain is exploding after all that brain talk. I just want to thank you so much for listening. I really appreciate your time.